Hi everyone, and welcome to ABCs of Anesthesia. Now we're doing a Viva session here with Amy. This is where we go through a Viva just like in the final exam, and it's always interesting to do these because first of all, I look up some articles, I look up some evidence, and I try to make something as real as possible from a real life point of view. So I think they're pretty close to what our final exam Viva is like. There's a lot of discussion, there's a lot of difficult decisions. And it's just I feel like it is very much a real life situation, except that we're talking about it. So you get tested in a lot of different ways. So I think it's a really robust kind of process. So let's get started. Amy, tell us about yourself, where you're at.
So I have just done the written and thankfully got through that. And so now I'm waiting on the Viva, which is in about 2 or 3 weeks. I
Congratulations.
probably should know the exact number of days, but I don't.
Not enough.
Yeah, so it's been a bit of a up and down journey doing the Vivas. I started off quite atrociously, to be honest, because I had no structure. So I've very much been working on my structure, which I found has helped. Yeah.
Beautiful. And pretty much what everyone tries to do is, they try to get at least 1 to 2 Vivas a day, and then they've done that Viva, they pay it forward, and they help their mate out examining that Viva with that Viva as well. So it's a pretty rigorous process, and everyone does really terribly at the start. It's weird because we've given anesthetics for many years, but there's all these things where we're not tested in this way, and the primary exam is so onerous that I think it stunts our growth a little bit as well. So because we're focusing on a totally different set of I guess knowledge and style of examining, and now suddenly you're thrust into this absolute mammoth of an exam.
Yeah.
Hey, so what are the things that you find you need to work on and that you'll try to pay attention to, and any particular thoughts you had about your preparation so far?
As I said, I think structure has been really important for me because initially I was just like scattergunning thoughts out at random. And so I think what I'm realizing is that most of the knowledge is there. I guess it can't not be after you've worked so hard to get through the written, but it's just a case of remembering that you have got the knowledge, not panicking, and finding a way of getting that knowledge out when they want it.
Yeah.
So for me, I think that's the biggest thing.
Yeah, that's a really good point because I think a lot of people think the knowledge comes just from practice, but the knowledge comes because you had to do a written exam and an MCQ, because that's a very focused period. So anyone who doesn't have to do the written exam and the SAQ, I reckon it's a massive disadvantage to them. In this particular situation, the SIMG, the specialist international medical graduates, I have been told they don't have to do the written, but I think that's a massive disadvantage because trust me, as I go longer in my practice as an anesthetist, I'm not sitting exams in the same way, and my detailed knowledge and my up-to-date knowledge is only propped up because of running these courses and stuff. So if you're not doing that, you're losing a lot of the knowledge you used to have. And it takes, I don't know, the 9 to 12 months preparation for the written to really get back on track. So if you're studying for this exam without the written exam, please, you need that intensity as well. Let's get started. So for everyone, what we'll do for this, the actual Viva goes out on YouTube. And then all the feedback and the answers and everything are on the final exam course. So there'll be there'll be link in the show notes and link at the end to the final exam course where I'll run through feedback for everything as well. So let's get started. The first thing is a stem. So I will just share the screen. Can you see that okay?
Yes, I can.
It'll take 2 minutes to read that, make whatever notes.
Okay.
And Amy, that is 2 minutes. Candidate 1, 2, 3, do you understand the question?
I do.
Fantastic. So what are the components of informed consent?
So in order to provide informed consent, the patient's got to be able to understand the information that you're giving them, which would include the risks, the benefits, and the alternatives to the procedure. They need to be able to make an assessment of that information themselves, retain it for long enough to make a decision, and then they've got to be able to communicate that decision to you. And I know in this case, the patient is 14, but a patient can still have consent at the age of 14 using the principle of Gillett competence.
And so you mentioned weighing up the risks and benefits and being able to comprehend that information. Is there another word for that?
yes, probably, but I can't think what it is.
Yep. Is there any other aspect of it? So you've got the, they've got their competence, they've given information. Is there any other aspect that must be present?
They can't be under any sort of coercion from anyone else.
Right. So it's got to be voluntary as well. So you've got
Yeah.
competence, information, and voluntary. Now, you mentioned Gillick's competence. What is Gillick's competence?
That's when you determine that a child has got the ability or the competence to make a decision about their own treatment, despite them being a child rather than an adult.
And how would you establish that they have capacity?
I think it's just through your opinion, through speaking to them and making an assessment of what they seem to, whether they seem to be understanding and whether they what they're saying in response to you is appropriate.
Mm-hmm. You actually mentioned some of these points in the previous question. So you mentioned checking understanding, weighing the pros and cons, and then communicating their decision. Is there any other subtleties to this? What's the difference if this patient needed to take some medications versus having surgery?
Yes, it's to do with whether or not they can refuse treatment. Is this what you're meaning?
That's I was going to ask that as well.
Oh, okay.
Let's go with that. If this patient was an emergency procedure, let's say they had some horrific accident and they didn't want the operation, but they were about to die if they didn't have it, as a mind, because they're 14 years old, what would you do? Would they be able to refuse or not?
No, they can't refuse life-saving surgery.
Okay, good. And let's say this was something like they're consenting to take medications versus they're having a massive operation.
I
No.
can't remember.
Now, if the patient, let's say they're having this spinal surgery, if the patient didn't want to have surgery, what do you do at that point?
I think I would go through and see whether they appear to have capacity. It would need to be a multidisciplinary team effort to talk with the child and also the mother and anyone else, like if her father's involved as well, for example, to find out exactly why she didn't want the surgery, make sure that she understood the risks of not going ahead with the surgery, and also find out if there's any pressure either way from the parents or anyone else significant in her life. So that we can, and if we believe, which I assume we do, that scoliosis would be better managed now, then we just need to make sure that this is fully explained, and that, but ultimately they can refuse it if they want to.
Let's say this is medically indicated, that there are certain consequences that we can go into to having a scoliosis as untreated. Medically indicated, the family, the parents do want the child to have this, but the child doesn't want to have it. Well, you've done your multidisciplinary family discussion. She's got various reasons, being afraid of the surgery for various reasons. What do you do then?
I mean, this is a very tricky situation. It would be very difficult to go ahead against her wishes. This surgery, obviously it's important medically, but it's not an emergency. It doesn't need to be done in the next week or so, and forcing a 14-year-old to go ahead against her wishes is not going to be good for anyone, really. So I would give it more time, spend more time. Maybe I would organize for them to see a psychologist, and just work through it that way to see if we can, if she can end up feeling that it's the right thing to do.
And let's say at the end of that, the 14-year-old does not want to have this happen, but the medical team definitely says, look, this could severely affect her upbringing in the future. Does that change anything? Severely affect her health in the future, sorry.
Um,
No, that's good. So after discuss, so you correctly say we're going to now pause. We're not going to go ahead with this. Have a discussion. So she goes away and has a discussion with the family, and then she decides to then she agrees that everything needs to be done to correct this. So she decides to proceed with the surgery. Having a look at the stem again with all her past history, what do you want to know on assessment?
I think the things I want to know are related, like I would want to do a full history and examination and review all the relevant investigations with a particular focus on both her scoliosis and her asthma. So with regards to her scoliosis, looking at her chest x-ray, she's got severe scoliosis. So I'd want to ask more about the symptoms she's had from her scoliosis, how it was detected, when it was detected, have things been progressing? Has she got any neurological symptoms in any of her limbs as a result? And I'd also ask if it affects her breathing at all, because it's possible that she could end up with some form of restrictive lung disease from the scoliosis. And also whether she feels that it's affecting her neck movement as well, just thinking along in terms of managing the airway later. I would also be thinking about the pain management. I noticed that she's on paracetamol and diclofenac as well. So just it would suggest that pain might be an issue. So I'd want to clarify if she takes them for the scoliosis and if she's on any other medications for pain or has been. And in that case, how often she's needing to take those things. And also I would want to know if she's had any previous surgery for the scoliosis. And then in terms of her asthma, I'd want to know again when it was diagnosed, whether it's quite stable, what medication she takes, has these been changed recently, how often does she have exacerbations, and has she been into hospital? And when she has been in hospital, has she ended up in ICU? And does she ever take steroids? And if so, how frequently has she had to take them? And just ask about as well if there's anyone at home that smokes. Then I'd want to examine her mostly from a cardiorespiratory point of view, and then also related to her, because I'd want to do a thorough examination of her airway as well. So do my standard airway assessment, again, particular attention being paid to mouth opening and neck extension. I would want to assess her respiratory system, looking for her work of breathing, respiratory rate, saturations, looking at her air entry on each side and auscultating the chest to see if she's got equal air entry, and also bearing in mind her asthma. I'd want to see if she's got any current wheeze or added sounds at the bases at all. I'd like to then find out if she's had any pulmonary function tests. I've got an x-ray here, which I can look at, but it would be good to get a specific chest x-ray that shows the whole of the chest if she has got one. A peak expiratory flow would be useful so that I can determine her baseline and find out what she would say her normal baseline is. And I would also like to check her bloods, so full blood count, U's and E's, and coag, and she'll need a group and hold for this surgery as well.
Good. I'm about to show you some respiratory function tests, which I'll just do now. Are you able to see this screen?
Yes, I can. Yeah.
Yeah. What do you make of this respiratory function test?
Okay. So she's got a reduced FEV1, and her. Oh, sorry. I was just looking for her FEV1 to FVC ratio. Looks like it's is it 85%?
Yeah.
Okay. And she's got a peak flow that's 77%. So it looks like she's got she's got restriction, I would say, of her she's got some restrictive elements to her lung disease.
What makes you say it's restriction?
The reduced FEV1.
Yeah. So, and if you were to grade it, what would you say the severity of it?
Oh, I would say it's probably moderate.
Yeah, sounds good. So let's say she has what you see now as a moderate restriction. Her HB comes back at 90 as well, just to let you know that. And What is your plan for the decreased hemoglobin results?
Can you remind me again when the surgery was scheduled for?
For a couple of weeks.
Couple of weeks. Okay. So I think it would be ideal for her hemoglobin to be higher because this is a surgery that has quite a risk of bleeding. So starting at 90 is not ideal. I think ideally she would get an iron infusion with it being just such a short time till surgery. But if it's possible to delay the surgery by a week or two, even, that will give the iron longer to take effect and improve things. So I would speak with the surgeon to see if we could delay by a couple of weeks and give her an IV iron transfusion.
Anything else you want to check?
Check her hematinics, so check her vitamin B12, her iron. So do her iron studies, her B12 and her folate, and see if there's anything else that needs replaced.
Great. Is there anything else on the blood panel or any other investigations you might want?
So I would like a coagulation screen and use these.
Yeah. What else would you order for the operation?
And I would want to cross-match 2 units.
Before the cross-match, you assume you get a group and hold. What are you specifically looking for in the group and hold?
I want to know that she's not got any antibodies on the group and hold. Just because if she's got antibodies, there's a reasonable chance we might have to transfuse her, given she's already anemic and it's kind of major surgery. If she's got antibodies, we won't be able to get blood quickly. So we would need to have a lot of blood matched in advance so that we can give her blood if needed intraoperatively. So I would aim to be cross-matching at least 6 units if she's got antibodies and having it in the hospital ready to go.
Okay. What is your anesthetic intraoperative plan?
So I'm going to make sure that she's got adequate IV access. She'll need 2 wide bore IV cannula due to the risk of bleeding. This surgery is going to be prone, so I'm going to need to make sure that I've got access to that. I would want to have standard monitoring, but plus I would like to have, I would want an arterial line, but because she's only 14 and I don't need it for induction, I would be happy to put that in after induction. I would want BIS and neuromuscular monitoring, and I would want to have a trained assistant and prepare my drugs and equipment. So I'd want to calculate all the drugs as to her weight, and then all the drugs that I'm hoping that I don't need but might need. So all the emergency drugs, I'd have calculated the dose and the volume that I'll need to give so that I can quickly draw them up if required. In terms of my airway, it would depend on how difficult the airway looks, but most likely I'll be using a CMAC3 video laryngoscope, and I would have a bougie available. I'd use a size 7 tube, and it would just need to be very well secured because it's going to be very difficult to access once surgery's there, and there's a risk it might displace.
How do you secure the tube?
What's that, sorry?
How would you secure the tube?
So I would use tape, and a lot of tape, and bearing in mind as well there'll be a lot of secretions coming out, so I'll make sure there's space for the secretions to come out so that they're less likely to pull behind the tape and then force the tube out.
How do you make sure that there's enough space for secretions?
Just by making sure that there's a gap so that the whole mouth isn't covered. Just make sure there's a hole in the tape of some sort where the way I've wrapped it around.
What are the other options for securing the tube?
You could tie it. I mean, often what I would do is have a tie and tape. So tape it first and then tie so that it's kind of got that double safety
Is there anything else for the anesthetic plan that you're most concerned about?
So the other things would be that, again, they're going to be prone, so I need to make sure that all my monitoring is well secured and fixed on, and I'm going to need to be very careful with my pressure points because they just because of the positioning and the fact it's going to be very long surgery because it's multiple level surgery. I would want to make sure the patient was kept as warm as possible, because that will reduce the coagulopathy and the risk of bleeding. And have IV, even the IV fluids, I would want to be put through a warmer as well. I would also need to speak to the surgeons before we went off to sleep, just to find out what sort of spinal monitoring they're planning, if any. So if they're using any motor evoked potentials, that will mean that I could use muscle relaxant at the start, but I need to make sure it's worn off or I've reversed it by the time they come to requiring the motor evoked potentials to be used. So I would be performing a relaxant GA.
You mentioned pressure. Is there anything else you focus on in terms of pressure?
There's the pressure on the pressure points, then there's trying to keep the abdomen free so that you're reducing the risk of DVTs, you're less likely to reduce venous return, and also it's less likely to affect your ventilation. And also there's the risk of pressure to the eyes, so you need to make sure the eyes are free.
What is the risk of visual loss in this kind of in the prone position?
So it's much higher than for other types of surgery, particularly during spinal surgery, and the risk's increased if it's prolonged spinal surgery, or if the patient's obese, or if there's excessive blood loss. So I think the risk is around 1 in 60,000.
Mm-hmm. Okay, good. As you do a successful intubation and you're able to position the patient very well, what do you set your ventilator at?
So I have a weight for this patient?
Yeah, 50 kilos, let's say.
50 kilos. Okay. So I would be ventilating. I would want to avoid high PCO2s, because that could cause venous dilation and increase the risk of bleeding from the spinal surgery. So I would have her ventilated at about 7 mils per kilogram, going for between 6 and 8, and then initially at a rate of 14. And I would use pressure control volume guarantee ventilation to achieve this with the minimum pressures.
Right. And let's say that your pressure go quite high and they're alarming at the 350 volume. Why is that in this patient?
Well, there's a number of reasons, and I'd need to check which of those reasons it is. My concerns would be that it's either because the tube is moved endobronchially during positioning, or that there's some sort of kinking going on in the equipment. And the other thing I'd be concerned about would be that the abdomen's being compressed and splinting the diaphragm. They would be my main concerns.
Anything else about this particular patient that could cause?
There's also the fact that she's already got restrictive lung disease as a result of her scoliosis, so her lung volumes might be reduced anyway.
Okay, so let's say you rule out the tube position moving, there's no kinks in the tube, the abdomen is free. Knowing that this is probably just a restrictive ventilation, how do you reset your ventilator to favor that?
So I would reduce my tidal volumes to, say, 280 initially, just choosing an arbitrary figure, and then increase my respiratory rate and see if that allows me to improve my minute ventilation, but with reduced pressures.
Is there any other setting that you can change?
You could change to because I guess the problem here is probably the actual the inspiratory breath. So you could increase the inspiratory time, so you could reverse the IE ratio.
What would you reverse to? It starts at 1 to 2?
Yep. So maybe 1.5 to 1.
Okay.
That's not quite reverse, but it's I don't want to fully reverse it.
There's going to be a long operation. 2 hours into this quite long, reasonably complex operation, you've gone for a break, your register is there, you return to theatre and notice there's now increasing araminol rate to about 8 milligrams an hour to maintain a blood pressure of 100 on 60. So 8 milligrams an hour, blood pressure 100 on 60. What do you do?
Okay, so I'll firstly just check that my arterial line transducer hasn't fallen, and then I'll have a quick scan of the monitors. So my concern here with the increasing metaraminol requirements would be that maybe there is excessive bleeding. So I would quickly check that there's no other cause that I can see. So no arrhythmia, that I'll have a look what my end tidal CO2 is doing and check that I've not got high pressures, high airway pressures, which could contribute by causing a sort of obstructive cause to the hypotension. And then I would quickly scan the surgical field and tell the surgeons and see whether they feel there's a lot of bleeding. And I would ask the theatre tech to just let me know what's in the suction, and have a quick look under the table as well to see if there's any blood on the floor. And then
Just to give you some information, the surgical field is all normal. The end tidal CO2 is about 30. It's been around that for this whole time. You also checked the pressures at 20, giving you the adequate volume that you had. Yep.
Okay. I would also just quickly check that there's no evidence of any swelling or rash that might indicate that it could be related to anaphylaxis to something that we've given. And I would, and as best as I could, I would just feel for the trachea to make sure it's central and auscultate the chest. And then the next thing I would do is take a gas so that I can actually check the hemoglobin and see what that's doing.
You saw pre-op HB was 90. It rose to 100 after the iron transfusion. And when you've rechecked, it's 95.
Okay, so it doesn't appear that it's related to it doesn't appear to be related to bleeding then. I would give 200 ml bolus of fluid at this point, just to see if I can bring the metaraminol down. And I have another.
It has a temporary relief. So after giving the fluid bolus, the 200 mils of metaraminol just come down to, say, 5 milligrams an hour. And over the next few minutes, then it trends right back up to 8 to 9 to 10 milligrams an hour. Okay.
Well, I'll give another bolus of fluid, and whilst I'm doing this, I'll have another think about what this could be. So just looking again, what was my heart rate?
Your heart rate has been trending up as well. It started at 60, then it gone to 70, 80, came down with the fluid bolus, and is gradually going up again. It's also dependent on the metaraminol infusion.
Sure. Okay. So bearing this in mind, I've got transient response to my fluid. I've got increasing tachycardia and hypotension. My main differentials would still be that there's bleeding and maybe my hemoglobin just hadn't changed because I hadn't actually given much in the way of fluid, so I hadn't diluted yet. And my other thinking could be that it's some form of distributive shock. So thinking about sepsis, which is unlikely, there's no real reason in this situation why she would have suddenly become septic. There's not that we know of, she's not got any sort of hypothyroidism. And we've already looked, and I don't think there's any evidence of anaphylaxis. I think I would ask again the surgeons, are they sure there's no bleeding? Because I'll just explain what's happening, and I would do another gas now that I've given some more fluid as well, just to make sure that my hemoglobin is still stable.
How much fluid would you give before taking another gas?
I would probably, I mean, I've only given 500 mils, so I would give, she's 14, isn't she? So I'd give her at least a litre before I check the gas again.
Check the gas again, and HP is now 70.
Okay. So this would fit with bleeding being the cause of this decrease in blood pressure. So I would tell the surgeons that she's acting clinically like she's bleeding, and now we've also got hemoglobin drop. So is there any chance that she could be bleeding from anywhere that they've just not noticed? And I'd also ask if we could maybe peek under the drapes and see if there's any blood collecting under there.
They are still adamant that there's nothing in their field. There's nothing under the drapes. What do you do from that point?
Okay, well, in the meantime, I'm going to need to I need to do something about the increasing metaraminol requirements and the low hemoglobin. So I would call for 2 units of blood to come from blood bank. And I would also call for extra help because I'm going to need help to administer the blood. So I would ask I would allocate roles when people arrived.
Let's say you get all of that sorted and you're ready to resusc this patient. Where do you go from there after you've got resus in motion?
So the blood has been given. I need to have a think about where this blood is going.
So let's say the surgeons are adamant that there's nothing in their field, what do you do?
I guess I could ask them if there's any chance that there could be bleeding somewhere where they can't see, because their blood is going somewhere and I've got no other explanation for it.
And they say, yeah, look, there is a chance it's complex operation. Maybe we put a nail in something. What do you want us to do?
Okay. Well, I would say, yeah, I think that's a strong possibility in this case, given the way the patient's behaving. And I would ask them what they need to do to determine if that is the case, and if so, what they need to do to fix it.
Yeah, pretty good. And so let's say they say we can pack up here, we can go supine. If we're worried about a retroperitoneal bleed, we'll have to go supine and then get the general surgeons in or vascular surgeons in to do that.
Okay. Well, given that she appears to be actively bleeding, I would ask them to do that. So we would need to I've already called for help, so we hopefully have enough people, but we will need to move her onto her back so that we're able to do the laparotomy. And I would want to make sure that I'd given her, that she was as hemodynamically stable as possible before we performed the laparotomy, because there's a risk that if it's retroperitoneal, once they enter that space, any tamponade that's in there might be lost and there might be a sudden cardiovascular collapse. So I'd make sure that both my IV cannula were connected one of them to a fluid warmer and a pump set. And then I would ask for the Belmont to be brought in so that I could connect that to the other one. And I would also at this point activate the massive transfusion protocol so that we've got plenty of blood products available.
Fantastic. That's the end of the Viva.
Ah.
Okay, so everyone on YouTube, we're just going to pause it there. And I'll give a lot of good feedback for that, Amy. Exceptionally well done. That was a really tricky situation, and the method and the structure and the way you processed through that, I thought was really, really great. So thanks all for watching and listening. And for the full course, check out the final exam course. Excellent. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.